nursing CEs for our hospital, we welcome you to another program. This evening, obviously, we'll be talking about diabetic nephropathy. The reason we're doing the program, as many of you probably know, diabetes mellitus accounts for well over half of the new starts on dialysis or renal replacement therapy each year. It's a condition that in many situations is preventable through better glycemic control and other general care for diabetes. So having a program that focuses on how to reduce those patients with nephropathy and diabetes progressing to end-stage renal disease is something that we thought was very important, and it's the reason we're bringing the program to you this evening. The program this evening carries 1 hour AMA Category 1 Physicians Credit CME and 1 hour of Virginia Nurses Association CE credit. Sovah Health is credited by the Southern States Collaborative for providing Category 1 AMA CME and by the Virginia Nurses Association for providing a nursing CE credit. The program this evening was developed to promote certain desirable physician attributes, including patient-centered care and employing evidence-based medicine. The needs assessment, as I just highlighted to you, comes from the very important public health issue of the high prevalence of diabetic nephropathy leading to end-stage renal disease. Dr. Boland, myself, members of the Sovah Health CME Committee have no commercial relationships to disclose to you this evening, and there is no commercial support for this program this evening. It, like our other programs at Sovah Health for CME activities, is supported by the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. Dr. Landis, who founded the Southside Urology and Nephrology practice, also known as the Danville Urologic Clinic, or the DUC if you're a Danvillian, set this fund up upon his retirement from active clinical practice, and in his generosity as providing an endowment to support speaker honorariums for continuing education programs throughout our community. You will receive this evening by email, and you'll also have the option to obtain it through a QR code and evaluation form. That evaluation form has 7 or more questions on it. We always like to bring your attention to number 4, which asks, what will you be changing in your practice based on what you learned this evening? And we just remind everyone that's for everyone on the call doing an evaluation. That's not just for the docs, as it were. We all practice medicine within our scope of practice, so we hope you'll take a few minutes to answer that question for us. The evaluations are very important to us. We review them. The speaker reviews them. It helps us look at our program success, and it's also very important for us planning future programs. When you do get that eval form and send it in, it will ask you to enter again your name and your email address. Please give us your full name, and as much as that name is what will be generated electronically on your CME certificate. So no nicknames or short names or phone numbers, etc. For the name entry. We'd like to have a good record of that. Finally, if you're sharing the logo tonight with someone else, which is great, we're delighted to have any healthcare professional that wants to participate, please let us know so we can be sure the person with you, if they're not already registered formally for the call, that they get credit for their attendance. Mary will also be placing in the chat box a QR code that will allow you to access evaluation if you prefer to get at it that way. I would point out that the evaluation forms are not required to get CME credit for physicians, but they are required to be received from nurses and nurse practitioners in order for nurses to get their CE credit. I remind the residents who are on the call tonight, and I'm glad a number of you are on the call, that you do not have to worry about maintaining your CME certificates. Your coordinators, Dara Johnson and Ms. Galvez, will be monitoring that, and they track your participation for you. I also would thank the residents that are on the call tonight, and Dr. Boland's aware of this. She's kind enough to make this talk tonight, if you will, the completion of a 2-hour noon session I had with the residents today, talking about a number of other types of renal disease, glomerular disease, and chronic kidney failure in general. I also like to take the point at this time, each time we have a program, to specifically thank Mary Kent for her help in developing the program and Jennifer Goodman for the nursing aspects. Without their help, we could not do these programs. And I'm very, very grateful for their support. I know that Dr. Bowen's going to encourage questions, comments, and as that is the case, we urge you to put that in the chat. Mary will be monitoring that, and at the end of the program or the formal presentation, Dr. Bowen will address all those. If you want to come online with a oral, meaning you're talking to tell us rather than writing it in chat, you're welcome to do that. If you do that, once you ask your question, please mute your phone to listen to the answer, in as much as it reduces the feedback that occurs in the system. You're more than welcome to do more than one question, more than one comment. In fact, sometimes the question sessions are just as valuable as the formal presentation. I'll remind you that we have one more program scheduled for this calendar year. So next Thursday night, we're delighted to have Dr. Christopher Holstead back to do another program. Many of you were on the call last week when he did an outstanding program on the current issues of illicit drugs and substances on the streets of our community and Charlottesville, where he's based. If you didn't get to hear that talk, there is a recording available. If you'll contact us, we'll tell you how you can listen to it. He is the chief of the Division of Medical Toxicology at UVA. He also manages the Blue Ridge Poison Center, which is located at UVA. And his services there in his center are the individuals that are called from all the emergency rooms throughout the southwest and western parts of the Commonwealth. This talk next week is going to be on envenomated patients. That's snake bites, spider bites, tick bites. There's been a real resurgence of tick injuries recently. This is an unusual talk, and it's something that I think you really can't find anywhere else. And he's just a superb speaker. So I hope you make plans to be with us next Thursday evening, same time, same station. We do not have any programs planned for December. We find that's really tough because of the many holiday activities people are involved with, but we will be coming back with programs beginning in January and towards the middle of December. For those of you on our distribution list, and all of you I think probably are, we'll let you know what we have scheduled for January and look forward to a lot of great programs in the coming year. That leads me to the really privileged to introduce you to Dr. Bowen tonight. She's an associate professor of nephrology and internal medicine at the Wake Forest University School of Medicine in Winston-Salem. She is originally from Texas and received her undergraduate degree from Texas A&M, graduating magna cum laude, how's that, in biology. She followed it with her MD degree from Texas A&M, and then had the privilege of doing her internal medicine residencies and nephrology training at the North Shore University Hospital and Health Systems, which is on Long Island in New York, and it's one of the premier care centers for the greater New York City area. She's been at Wake Forest for a number of years. It's been her, if you will, professional academic home since finishing her training program. She has been repetitively recognized over the past 10 years in the so-called Best Doctors in America surveys. She has been nominated and has received numerous teaching awards at Wake Forest. She is a real star educator among the medical staff and the teachers that are centered at Wake Forest. We are just delighted to have her. She has numerous publications. She has numerous research studies she has led in the past number of years. And tonight, I hope everyone will enjoy hearing her talk about diabetic nephropathy. So that being said, Dr. Bowen, it's all yours. If you'll bring your slides up, mine will pop off. Thanks so much.
Thank you so much. I appreciate the intro. And let me go ahead and get that up. I think are y'all able to see my screen?
You just want to go to full screen now?
Yeah.
Yeah.
And are y'all, we're good now?
We are.
Okay. Thank you again, Dr. Moore. I appreciate the introduction, and thank y'all for having me here. I look forward to the discussion afterwards. Danville we're very close to, and I've really only been there once, unfortunately. But what I remember is a very peaceful, beautiful weekend, lots of greenery. I unfortunately did have to ride a horse and did not fare very well with that. So I definitely must come again without the horse involvement next time. So I am pretty informal, but I have reserved kind of questions to the end just to keep the flow of the talk going. But I do, look forward to the conversations at the end. So as far as the diabetic nephropathy, this is actually a really exciting time period for us with diabetic nephropathy because treatment has really changed dramatically, especially over the last 10 years, but even in the last few years, we've seen a lot come about with our management. And we know that these therapies not only are targeted for the pathophysiology of diabetes, but also directly address underlying kidney injury itself. So we'll be touching on all of this as we go along. And you know that diabetic kidney disease is one of the more serious microvascular complications that we have. And it affects about 40% of all of our diabetic patients. And as Dr. Moore alluded to, it accounts for about 45% of new start dialysis patients that we have. But why do we care about all this? Outside of the prevalence of it all, we care about it because the impact of it actually goes beyond the kidney itself, right? So we see patients with our diabetic kidney disease have roughly 3 times higher all-cause mortality, especially, and a large part of this is largely because of cardiovascular outcomes. They have risks that rise with albuminuria. They have, as their GFR declines or as their albuminuria increases, you see that this risk for mortality starts very early in their disease process. They have 2 to 3 times higher likelihood for cardiovascular disease, as well as hospitalizations from heart failure. So DKD or diabetic kidney disease doesn't just affect our kidney outcomes, but it really drives a lot of cardiovascular disease and mortality. And it leaves us all a very huge opportunity to really jump in and try to change the trajectory of these patients' lives. Let me see here. And I'm actually going to do one quick thing, if that's okay. Mary, if you can let me know, I think my screen is a little bit off.
Okay.
Sorry about that.
In what way?
Let me see. It's not showing. What do y'all see here?
Okay, now I see, I'm seeing your notes. So we're like in note view. And now I'm seeing full screen. And I'm seeing your
Okay.
objective slide.
Okay, perfect. Yeah, I'm a little off here, but that's all right.
Was it not advancing for you?
Yeah, something's off, but let me try to keep going and see. Hopefully this will correct itself then.
Okay.
So as far as the objectives, that we're going to spend the better part of the hour really concentrating on management of diabetic kidney disease. But I am at the beginning going to briefly touch on pathogenesis, not because I want y'all to walk away with any kind of nitty gritty of the specifics, but really so we can all appreciate that the management of diabetic kidney disease has really kind of evolved in parallel with our understanding of this pathogenesis. And then we're going to talk a little bit about screening and diagnosis. Y'all do this on a daily basis to begin with, but we'll kind of review some of this. I understand there's some learners in the audience, so that it's always good for us to review. And then talk about some risk mitigation that we can do with our patient population, specifically with lifestyle changes as well as with blood pressure control. And then land on the different modalities that we have in terms of therapy. So first, kind of looking at the pathophysiology mechanisms. So I kind of think of DKD or diabetic kidney disease as a result of 3 overlapping processes: this metabolic dysregulation, inflammation, and some hemodynamic perturbances or stressors. So it's really important to recognize that all 3 of these kind of feed into one another, feed off of one another, and ultimately kind of result in some progressive fibrosis or kidney failure. And it's really important to remember that not all patients are going to behave the same way or experience these pathways in the same way. There's a lot of heterogeneity we know in our diabetic population, but also in our diabetic kidney disease population. There's going to be a lot of heterogeneity in these groups, and a large part of that's based on their genetic makeup or their innate immunity that will determine that. But looking at these, what do we see? So we can see with metabolic dysregulation, you get increased adiposity, or especially our visceral fat. That can lead to this chronic low-grade inflammation. The low-grade inflammation is going to result in inflammatory mediators that end up disrupting insulin signaling and cause insulin resistance. As a result, you get hyperglycemic, dyslipidemic, and all of that can really trigger some damaging biochemical pathways. A number of them are listed here, but the one that is important to take note of is the advanced glycosylation end products that we hear about. But all of these pathways will lend to more reactive oxygenation species, which is where we get our oxidative stress, our endothelial dysfunction, and increased inflammation. And that increased inflammation comes about because of increasing some transcription factors that also allow for increased macrophage recruitment. And that's really important in our diabetic kidney disease, because this is one of the hallmarks of diabetic kidney disease, is this macrophage infiltration into the kidney itself. And this oxidative stress and this inflammation kind of are tightly intertwined with one another, and really create kind of a vicious cycle where one begets the other. And so all of this just from that metabolic dysregulation, right? But then we have this aspect of hemodynamic stressors. So all the while where the metabolic dysregulation is occurring, you also have diabetes altering blood flow to the kidney itself. And that can happen because with the hyperglycemia, you filter more glucose. That glucose gets reabsorbed by that sodium glucose cotransporter, which we'll talk about with the SGLT2 inhibitors. And so you get less sodium that gets to your macula densa. Our kidney sees that and says, hey, I must not be getting enough blood. And so in response, it vasodilates that afferent arteriole. It activates the RAS system, which will cause vasoconstriction of the efferent arteriole. And in normal conditions, that helps us preserve our GFR, right? So physiologically, we need that. But in these conditions, this isn't physiologic. This activation of RAS continues on. And as a result of that, you get increased glomerular capillary pressures. And that increased glomerular capillary pressures is very important in the early findings of diabetic nephropathy, where you can see hyperfiltration. But as that continues, you'll get podocyte damage, albuminuria, and further progression of the diabetic kidney disease. And this is that where we see ACEs and ARBs and SGLT2 inhibitors really coming into play to help minimize some of that progressive feature to it. And then lastly, we have the inflammation realm. So for inflammation and fibrosis, we see that chronic metabolic as well as hemodynamic stressors lend towards kind of a persistent inflammatory state. And we talked about that macrophage infiltration, and it really converts into a more pro-inflammatory type of macrophage. They also have chronic activation of your mineralocorticoid receptor, and that can also lend to more fibrosis and inflammation overall. So all of this kind of conglomerates together to create a really vicious progressive picture that we see. So stepping a little ways from the pathogenesis, kind of going into the clinics of what you and I might see. So how do we define diabetic kidney disease? So KDIGO actually defines chronic kidney disease as reduced kidney function or kidney damage. So they define kidney function or reduced kidney function as less than 60 mLs per minute for at least 3 months. And these patients may or may not have markers of kidney damage. Now, they define kidney damage as any one of these things where you can have abnormalities in the urine with albuminuria, hematuria, urinary sediment changes. You might see abnormalities in biopsy or abnormalities in imaging. Also, you can see this with electrolyte changes, especially in our tubular disorders. So those are markers of kidney damage. And so they define CKD as markers of kidney damage for at least 3 months, with or without changes in GFR, or changes in GFR for 3 months, with or without markers of kidney damage. So diabetic kidney disease is basically diabetic patients with chronic kidney disease. And this is important to kind of take a step back and think about is, traditionally and historically, when we've talked about diabetic nephropathy, we're usually talking about our patients that have type 1 diabetes, that have albuminuria, that have diabetic retinopathy. They might have microalbuminuria or macroalbuminuria. But over time, we've learned that not all kidney disease and diabetes is as straightforward as that. There's a lot of heterogeneity, as we keep mentioning. And so that means basically not all patients will follow that same pattern. And we know on biopsy, we can see lots of different types of pathologic diabetic disease. So to that end, the more appropriate term probably is diabetic kidney disease, or DKD. That way we're more inclusive of the pathologic features of it. Now, as you guys may know, we don't typically biopsy a lot of our diabetic patients. And so that KDIGO actually recommends, instead of using diabetic kidney disease, to only use that when we biopsy the patient. Until then, to call them diabetes with CKD. So that might be an important distinction. So kind of stepping back, we're going to talk a little bit about screening. Again, you guys do this on a daily basis. So who do we screen? How do we screen? So screening really for diabetics, both type 1s and type 2s, is recommended to be annual. What we do know is that our type 1 diabetics, we want to start about 5 years after that diagnosis, because that's sufficiently long enough duration to have developed albuminuria and changes to GFR that's going to be appreciable. In our type 2 diabetics, we can actually start to screen them at the time of diagnosis, because it's presumed that our type 2 diabetics have likely had asymptomatic disease for quite some time prior to the actual diagnosis. So how do we screen them? We want to use a spot albumin to creatinine ratio, and you can also do a 24-hour collection, but that's oftentimes cumbersome for the patient. Sometimes there's a lot of disconnect in terms of patient understanding with that 24-hour collection. So a spot works really well. So a spot albumin to creatinine ratio. And then you want to check their eGFR, whether that's a creatinine-based eGFR or a cystatin-based eGFR. And if it looks like if the results are positive, then we're going to go ahead and repeat that to make sure that there is continuance or consistency and persistency. And then diagnosis is largely based on persistent albumin to creatinine ratio greater than 30 milligrams per gram, or a persistent eGFR of less than 60. All right, and let me see. And again, Mary, I'm sorry, I am seeing different screen on mine than what I'm talking about. Are y'all seeing the clinical screening?
Clinical screening of DKD.
Okay. Yeah, my other screen is showing me something entirely different. So let me see if I can fix that. Sorry for the technical difficulties, and that's despite our efforts to not let that happen. Okay. There we go. I think we're caught up here. There, perfect. All right, sorry about that, guys. Hopefully this will be in tune with what we want. So clinical diagnosis of diabetic kidney disease, like I said, many of times we do not actually biopsy these patients. And so diabetic kidney disease is a diagnosis that's clinical or presumptive. actually, when we do biopsy these patients, it's usually to confirm another alternative etiology when our suspicion is high enough for it. So this clinical diagnosis for diabetic kidney disease consists of, like we said, persistent albuminuria greater than 30 milligrams per gram of the albumin to creatinine ratio, or a decline in GFR for at least 3 months. We may want to consider a diagnosis of diabetic kidney disease in our patients with diabetes greater than 5 years, in our type 2s that have at time of diagnosis. We may also want to consider it in patients that have presence of proliferative diabetic retinopathy. This tends to be very highly predictive of diabetic kidney disease, but the absence of retinopathy doesn't necessarily exclude diabetic kidney disease. And we also see in non-proliferative retinopathy that there is some bit of correlation to diabetic kidney disease, but that correlation isn't quite as strong as that of proliferative. And then we also want to make sure we've ruled out alternative etiologies. And what do I mean by that? Well, we want to consider other causes of kidney disease in our diabetics if they don't present in a way that fits the clinical picture. So in our type 1 diabetics that have only recently been diagnosed, we may want to consider an alternative cause for their kidney disease if they have a lot of proteinuria or worsening kidney function. We may want to consider it if they don't have retinopathy, as well as if they have other systemic findings for other kinds of diseases that affect the kidney. And then we may want to consider alternative etiologies if their urinalysis has red blood cells, white blood cells, CAS, or if there's a rapid rise in their protein spilling or a rapid rise in their creatinine. Now, those two don't quite fit the normal trajectory that we expect with diabetic kidney disease or kidney disease progression. So when we see that rapid rise, you should really take a step back and say, is something else going on here? So our role of our PCPs is really to facilitate early screening and diagnosis, implement early interventions when indicated, and get them over to nephrology early as well. And all of this is with mind to help prevent cardiovascular mortality and morbidity, as well as slow CKD progression. And especially now that we're having a lot more therapy options, I think this will really become something that's very true and needed. Here on this right-hand side, we see the CKD heat map. And this helps classify CKD, not only based on cause of CKD, so whether it's diabetic or IgA, but we're also classifying CKD based on albuminuria, normal albuminuria, moderate versus severe albuminuria, as well as based on their GFR. And we see it kind of trick down the different levels of GFR. And it's important to remember that this grid is actually a great roadmap for primary care physicians, because it gives kind of a practical guide of what to do with your patients. You know, when these patients need to be screened versus treated, when they need to be referred, and then also how often their labs should be checked. So these numbers in these boxes are how often. So someone with normal albuminuria, less than 30, with a GFR of 70 would need to be screened and at least checked on annually in terms of their lab work, as opposed to someone that has a more severe GFR or more severe albuminuria. And the color coding that we see here is the prognostic component of it. This grid helps depict kind of risk of progression in terms of morbidity, CKD progression, as well as mortality. And so we see that as albuminuria worsens, as well as GFR worsens, you really get into the higher risk groups. So with that kind of all as our background behind us, let's kind of shift gears and focus on how do we manage these patients? And that's what we'll spend the rest of this talk doing. And this is what we see in this diagram here, that diabetic kidney disease requires kind of a comprehensive approach from all different aspects to really help these patients' trajectories or move these trajectories along in a different way. So what do we see? On the base level of this pyramid, we start with lifestyle changes and self-management, diet, exercise, smoking cessation, and healthy weight. And these are going to be the foundation for not just diabetic kidney disease, but all CKD. Now, the second layer, or the first line, is the first line drug therapies. These therapies have strong evidence for slowing kidney disease as well as cardiovascular outcomes. So we have RAS blockade for hypertensive and patients with albuminuria. We have SGLT2 that have good data to showing kidney as well as heart protection. Metformin is our kind of foundational glucose lowering therapy, as long as the GFR is greater than 30. And then statins we recommend in patients, all diabetics, whether type 1, type 2, as well as our CKD patients. The next level of therapies to add provide additional heart and kidney benefit. So we have the GLP-1s, which is advocated to provide cardiorenal benefit, as well as glycemic control. And it's thought to be the next add-on when metformin and SGLT2 is not adequate enough. And then the non-steroidal mineralocorticoid receptor antagonists like finerenone that we can use for persistent albuminuria despite other agents being on board like the RAS blockade and the SGLT2 inhibitors. And then aspirin therapy, consider lifelong for those that you're using it for secondary prevention, but also could consider for primary prevention in our patients that have high cardiovascular risk. And then we kind of fine tune at the top where we're really trying to get that glycemic control, the blood pressure managed, and the lipids managed. And then this yellow circle here is just to remind all of us, this isn't a one and done. It's really something that we need to continually reassess in our patients. And I think as we have more and more therapies available to help our patients, and as we take a look at this layered therapy, something that might be really helpful for all of us, both primary care as well as nephrology, is really building into our documentation, much like heart failure does, to make sure that we're checking off the boxes, to make sure that we know why the patient is not on an SGLT2 if they are a diabetic patient, to be able to document that so that we can systematically kind of work through this treatment plan with the patient. So next, we'll talk a little bit about kind of risk mitigation with lifestyle modifications. Now, we want to talk to all our patients, whether CKD, but also with the diabetic kidney disease, about healthy diets. And these are diets that we're going to encourage to have high in vegetables and fruits, whole grains, legumes, fibers, unsaturated fats, and nuts. You want to do a diet lower in processed meats, refined carbs, sweetened beverages. This is actually probably good advice for any one of us in the room, right? So these are all important things to educate our patients about, but always be mindful of kind of social determinants of health that may impact what food actually ends up on the table in front of our patient population, to help them navigate through that as well. The recommendation for protein intake in our diabetic patients is about 0.8 grams of protein per kilogram per day. And then the sodium intake, especially in patients that are hypertensive or there's concern for volume management, really ensuring sodium intake less than 2 grams per day. And then smoking cessation, weight management. And then moderate intensity is recommended, at least 150 minutes per week, or at a level that's compatible with their cardiovascular and physical tolerance. So what blood pressure targets should we really go for in this patient population? So KDIGO for its CKD population actually recommends a blood pressure of less than 120/80, which is a pretty tall ask for a lot of our patient population. And the data for this, supporting this guideline, really comes from the SPRINT trial, primarily the SPRINT trial, as well as a post-hoc analysis of the ACCORD trial. However, what we know is that the benefit of that intensive lower blood pressure may not be as clear in our diabetic patients. And why is this? Well, SPRINT trial, although it showed significant reductions in cardiovascular mortality as well as all-cause mortality in that lower blood pressure arm, they excluded patients that were diabetic for this trial. So how easy we can apply it or extrapolate it isn't as clear. Now, the ACCORD trial, they, on the other hand, did enroll diabetics and randomize them to either a lower blood pressure target of less than 120 or a higher blood pressure target, the standard arm, of less than 140. But their trial results were pretty conflicting. The initial trial results actually showed no improvement in primary benefit of cardiovascular risk. So that was completely the opposite of what SPRINT showed. Later, their post-hoc analysis did show some benefit in the higher cardiovascular risk group. But again, the data was pretty conflicting. And so is this really what we need to target, this less than 120/80, or should we go for something else? So looking at other societal guidelines, we see that most are in agreement that less than 130/80 may be a good choice, especially in patients that are higher cardiovascular risk patients. And so that less than 130/80 tends to be what I initially start off for. And that's important to note. All of these guidelines and their targets that they give are initial starting points, right? So I initially start off targeting less than 130/80 in my diabetic kidney disease patients, and then considering a lower target in patients that are higher cardiovascular risk or have increased proteinuria. And it'll be important to recognize that a lot of the societies are actually going towards more lower blood pressure targets to help with cardiovascular reduction and CKD progression. And then the other thing is important is to individualize your targets. So look at the patient in front of you and really determine what they're able to tolerate. And one thing that I try to explain to our residents is sometimes starting low and going slow may actually get the job done well as well, because a lot of times what we see is once a patient has a bad taste about a medication, it's really hard to get them back on board with that medication. So sometimes starting at a lower dose and then doubling that dose after they've been tolerating it may help them acclimate to that change a little bit better. And then what agents should we use in our patient population, this patient population? Well, we know KDIGO recommends using RAS inhibition for anybody with CKD, high blood pressures, albuminuria, and diabetes, right? So that A2, A3, moderate and severe albuminuria. And so RAS inhibition would be first line. Our second line is the dihydropyridine calcium channel blockers or a diuretic. But then you can also think about the non-steroidal mineralocorticoid receptor antagonists if they still have continued proteinuria. And then lastly, the steroidal mineralocorticoid receptor antagonist will be helpful. So the remainder of this time, we'll talk about the different modalities in this pillared system that I keep kind of hinting at. So before 1993, we really didn't have much in the way of options for slowing diabetic kidney disease outside of glycemic control and blood pressure control. And then in 1993 came the captopril trial that kind of changed how we looked at RAS blockade in our patient population, and it really helped hone in on the importance of RAS blockade for diabetic kidney disease progression. It showed a reduction in kidney decline by 4 to 6 mLs per year. But what we realized that even with that reduction in eGFR by 4 to 6 mLs per year, that still was leaving some substantial residual risk behind, meaning that normal aging GFR declines by 0.7 to 0.9. And so we're really not getting our full amount or full effect. And so ACE and ARBs likely are not alone are not going to be enough treatment for our patient population. And so that's where the emergence of SGLT2 inhibitors, the nonsteroidal mineralocorticoid receptors, as well as GLP-1 really shifted this paradigm around. Now we can think about diabetic kidney disease really in the way we think about heart failure management, using that pillared system where we use multiple evidence-based therapies and combine them that target different portions of the pathway to help really maximize and optimize our care of these patients. So just like with heart failure, where you have beta blockers, ACEs and ARBs, the MRAs, and diuretics all working together, the diabetic kidney disease paradigm now has its own 4 pillars. We're going to start off talking about the RAS inhibition, but then we'll walk through all the different pillars that will work on different aspects of pathogenesis of diabetic kidney disease. So this slide shows the renin-angiotensin-aldosterone system. Most all of us are familiar with this. For the younger learners in the group, just wanted to kind of briefly touch on this cascade. So it starts off with angiotensin, an angiotensinogen made in the liver. It gets converted to angiotensin 1 by renin. Angiotensin 1 then gets converted to angiotensin 2 by the ACE enzyme that's produced in the lung. And then angiotensin 2 acts on multiple organs, causing vasoconstriction, sodium retention, fibrosis. It can contribute to cardiac hypertrophy, as well as some glomerular hypertension and progression of diabetic kidney disease. So it has a lot of different impacts systemically along the way. But we can interrupt this pathway through direct renin inhibitors, through ACE inhibitors that work here, and ARBs that work here. And then if you'll notice that there is also a counterbalance regulatory pathway that occurs with the ACE2 enzyme. This arm right here, that ACE2 enzyme naturally converts angiotensin 1 as well as some angiotensin 2 into an angiotensin 1 through 7 peptide or product. And this is thought to be kind of this counterbalance. So as RAS gets activated, ACE2 kind of takes some of the angiotensin 1 out of the circulation so that it balances out the effects of RAS activation. But what's really interesting about this is that they're actually looking at these angiotensin 1 through 7 products, looking for analogs of these that might in the future be able to be used pharmacologically for blood pressure management, as well as reducing heart and kidney injury. So that might be something cool that comes up along the way. So of the RAS inhibition trials, these are some of the classic older trials, which is always helpful to kind of go back to. The Captopril trial was a multi-centered randomized controlled trial that looked at some 400 patients with type 1 diabetes and proteinuria, and it randomized them to either Captopril or placebo. And what it found was that it showed a 48% relative risk reduction in doubling of creatinine in the group that received the Captopril versus the placebo, and a striking relative reduction of 50% in terms of those that received Captopril versus placebo in terms of their endpoint of death, dialysis, or transplant. So really showed some dramatic improvements that really solidified the use of ACEs in this patient population. And this kind of ushered in 2 other trials, the RENAL trial as well as the IDNT trial. RENAL trial looked at losartan. It was a randomized controlled multinational trial that looked at type 2 diabetics receiving losartan versus placebo. And what it showed was that there was a 16% risk reduction in the primary endpoints, which included the doubling of serum creatinine. We see here was a 25% reduction with losartan, 28% reduction with progression to ESRD, and a 20% reduction in end-stage renal disease or death for those in the losartan group versus those in the placebo group. And then the IDNT, the last trial we'll mention for ACEs and ARBs, it was a randomized controlled trial that looked at irbesartan and amlodipine and placebo. And what it found was that there was a 20% risk reduction in those on the ARB versus placebo in terms of the primary endpoints. And then there was a 23% reduction in primary endpoints of irbesartan versus amlodipine. And then that was also true for the doubling of creatinine as well. So a couple of good data points that we've had for some time. There have been numerous other trials that came about in terms of ACEs and ARBs and their benefits, both cardiovascular and renal. That's really solidified that in terms of being a cornerstone in therapy of diabetic kidney disease. So what do we do on a practical standpoint? How do we work with our ACEs and ARBs? So we all know that when we start a patient on an ACE and ARB, we want to go ahead and monitor their kidney function 2 to 4 weeks after, as well as their potassium. So if we see an increase in their serum creatinine by greater than 30%, we want to review them for any other causes of AKI, correct any volume depletion, and any concomitant meds that might have caused that rise in creatinine. But really, if their creatinine rises by greater than 30%, we really should make sure that there isn't any underlying renal artery stenosis that we need to look for. Also, we want to look to make sure these patients are tolerating it in terms of hyperkalemia. And so those that are hyperkalemic, instead of stopping the drug, we may want to consider, reviewing other drugs that might be contributing to the hyperkalemia, advising for a lower potassium diet, or considering some diuretics or potassium resin binders. And that, I think, I want to stress the importance of, really utilizing Lokelma and Valtessa to help maintain our patients on ACEs and ARBs for longer periods of time, because we know there's so much, not only kidney benefit, but cardiovascular benefit. And then one other thing is also just retrialing these medications in the future. I think post-COVID, patients in general have been a lot more leery of medicines. And so when we're stopping an ACE and ARB for whatever reason, whether it's an AKI, really letting the patient know that these are really important drugs for their diabetes and their heart disease. And this is a drug that they likely will need to get back on, but we're pausing it for the time being to allow their, AKI to resolve, really selling it in that way so that they know that it isn't an all or nothing in terms of these drugs. And then here we have some of the side effects that y'all are familiar with. Keep in mind, angioedema is much more common in ACE inhibitors than it is in ARBs. And actually, if a patient has an event of angioedema related to an ACE inhibitor, it is within purview to go ahead and trial them on an ARB. And there should not be any cross-reactivity from that standpoint. So that's our ACE inhibitors, where ACE and ARBs we're very familiar with. So SGLT2 inhibitors, those really have changed kind of how we look at and how we manage diabetic kidney disease. They came about sometime in 2014, and these drugs initially used to kind of lower glucose, but what we found is that a slew of large cardiovascular outcomes trials showed that they weren't just great at improving glycemic control, but they actually had a lot of kidney benefits and heart benefits in terms of slowing kidney function decline, as well as reducing heart failure readmissions. And so actually some of the earlier meta-analysis for SGLT2 inhibitors, some of those earlier trials actually showed that there was a good deal of improvement in terms of progression to progression to dialysis, as well as reductions in heart failure. And these earlier trials actually did not include patients that had very advanced kidney disease. So they actually included patients that had more preserved kidney function. And despite this, we still saw a benefit from a kidney standpoint. And that really kind of led to kind of more kidney dedicated evaluations of SGLT2, like DAPA, CKD, Credence, and EMPIC Kidney. Those trials came about. So before we talk about those individual trials, I just wanted to kind of take a step back and go over the mechanism by which SGLT2 inhibitors work. So over here, we see the normal kidney, and we said that the macula densa is where we sense the amount of sodium chloride in the tubular fluid. So sodium delivery to that macula densa, it ends up playing a really key role in terms of regulating the GFR as well as the glomerular capillary pressure in our glomerulus. And this phenomenon is called tubular glomerular feedback. And the way I kind of describe it to my students is the tubular glomerular feedback is how each nephron kind of self-regulates its filter to decide how tight or loose it wants that incoming blood flow to be, to help keep a steady filtration. And so with patients' normal kidney function, we know that in patients that have low perfusion, hypovolemic, that you see decreased sodium chloride delivery as a result of that low perfusion and hypovolemia. And as a result of that decreased sensing of sodium chloride, the kidney says, hey, I'm not getting enough blood. And as a result of that, it will vasodilate its afferent arteriole to try to get more blood flow in. It'll activate RAS and cause a vasoconstriction of its efferent arteriole to try to really maximize and optimize the glomerular capillary pressure to maintain GFR in that low flow state. That's under normal conditions. But in our diabetic patients, we see that happening continuously, not because they're in a low flow state, but because that increased filtered glucose actually gets reabsorbed by that sodium glucose cotransporter, lending to less sodium actually getting to your macula densa. So your afferent arteriole is constantly vasodilated. You have increased activation of RAS, which leads to vasoconstriction of that efferent arteriole and this persistent glomerular capillary pressures that are increased. And over time, that can lend to progression by increasing albuminuria and podocyte damage. So the way that SGLT2s come into play is that they inhibit that sodium glucose cotransporter. So as a result, you dump more glucose and sodium. So dumping more glucose means you have glucoseuria, you reduce glucose, help with diabetic management. You dump more sodium, that helps with, takes water with it and helps with heart failure management. But with the kidney disease, how that helps is less sodium chloride get to that, or more sodium chloride get to that macula densa. And so it ends up reversing that vasodilation of the afferent arteriole and ends up reversing the vasoconstriction of the efferent arteriole and restores your glomerular capillary pressures. And that helps with decreasing progression of CKD in and of itself. All right, so now with that understanding of how they work, the SMART trial, there's a numerous SGLT2 trials out there, so I thought the better spent looking at kind of a meta-analysis of all the SGLT2 trials. So this looked at 13 placebo-controlled SGLT2 trials with 90,000 patients. It tried to evaluate kidney and heart protective benefits of the SGLT2 in patients with diabetes versus those without diabetes. It had a good portion of patients that had type 2 diabetics. It had patients that had anywhere from stage 2 to 3B kidney disease. And these were the trials that it looked like. looked at. These were the kidney dedicated trials, EMPA, Credence, and DAPA. And actually, all three of those were stopped early due to efficacy in their results. And then the outcomes that it looked at was kidney disease progression, AKI, cardiovascular death, and heart failure, as well as mortality and some safety data. So this is a little bit busy of a slide, so I'll just kind of walk us through this. And what it looks at is the kidney disease progression versus AKI in patients receiving SGLT2 versus placebo in the diabetics here versus the non-diabetics. And what it showed is that overall, both diabetic and non-diabetic population, there was a 37% risk reduction in kidney disease progression in those that were on an SGLT2 inhibitor versus a placebo. And this was true whether the patients were diabetic as well as in the patients that were not diabetic. So less 37% risk reduction. Now, AKI, there was a 23% risk reduction in the patients that were on an SGLT2 inhibitor, both true for diabetics and non-diabetics. Cardiovascular death and hospitalizations, there was a 23% risk reduction. Cardiovascular death, there was a 14% risk reduction for those that were on an SGLT2 inhibitor. All-cause death was 11%. And then there was really no significant reduction in non-cardiovascular death in the two arms, between the two arms. It also looked at, the meta-analysis also looked at some safety data, and what it showed is that ketoacidosis was 2 times more likely in the patients that were on an SGLT2 inhibitor, and amputations was 15% more likely in those on an SGLT2 inhibitor. And they did make a caveat noting that most of this risk came from one particular trial, and when they removed that trial, that risk subsided. And then there are additional side effects that they kind of looked at. The mycotic infections were more common in our SGLT2 patients versus placebo. And then there were really no differences in terms of fracture, hypoglycemia, or UTIs. No additional risk that was noted. And then this figure shows us kind of the absolute benefits and harms of SGLT2 inhibitors. And they express that in terms of events avoided or events caused per 1,000 patient years. So each panel is a different subset of patients. So this is the reduced heart failure patients, the preserved heart failure patients, CKD3B, and those with more advanced heart kidney disease. So what we see is that in our reduced heart failure patients, there was a 34 reduction or prevention of 34 cardiovascular events per 1,000 patient years. And that translated also in the preserved heart failure group to less 22 reduction in a cardiovascular event. So these are absolute reductions as opposed to percentages. So 22 events were avoided in that preserved group. And so even though that there was, the relative risk was about the same, the absolute risk you see is actually greater in those that have worsening heart disease, right? So that's an important takeaway from this is in that sicker population, we actually saw more events prevented. And then when they looked at kind of chronic disease, chronic kidney disease, that what they saw is in those that had a earlier GFR or CKD3B, there was 11 events, kidney events prevented for CKD progression. And in those that had more advanced disease, we were able to prevent more CKD progression. So again, the sicker kidney had the greater absolute gain overall. And so consensus statement from ADA and KDIGO is that SGLT2 inhibitors really now are recommended nearly for all patients with type 2 diabetes and chronic kidney disease, especially if their GFR is greater than 20 mLs per minute. And as far as when to stop or when we need to remove that, in patients that have already been on an SGLT2 inhibitor, if their GFR falls below 20, you can continue to keep them on that SGLT2 inhibitor all the way up until right about when they start dialysis. However, initiation really should be done before the GFR of 20 occurs. This is a good practical kind of guide for SGLT2 inhibitor use, who to consider, what are some high priority features, the contraindications we talked about. It's important to kind of educate our patients on this drug, let them know that they can stop it periodically for sick day protocol or before a surgery. Also in patients that have high risk for hypoglycemia, you want to definitely educate them based on their hypoglycemic symptoms, but also consider reduction of other medications to help kind of blunt that effect. And then same with volume depletion, educate them on their volume depletion symptoms, encourage hydration, but may want to consider some dose reduction of diuretics as well. And then we know that SGLT2, there's a number of side effects that we think of, the genital mycotic infections. We want to counsel them on genital hygiene, volume depletion, really be proactive in terms of getting them to hydrate. We do expect there to be a little bit of a blip in terms of their GFR, a modest drop in their GFR when we initiate the drug, so be aware of that. And the drug does not necessarily need to be stopped right off the bat. We also want to inform them of the risk for diabetic ketoacidosis as well as hypoglycemia. And then these are some of the different drugs that we have available in the US. And I know cost can be a big issue sometimes with getting these drugs covered in certain insurances. And so one thing that I'll say is that there is another generic bexigliflozin that it tends to be a lot more economical when I can't get EMPA or dapagliflozin covered. And usually I think Marley Drugs as well as GoodRx and even the Mark Cuban pharmacy carries the bexigliflozin. And it roughly is about $50 a month. So that might help get more of our patients covered. So the next kind of pillar we're going to go over is the nonsteroidal mineralocorticoid receptor antagonist. Now this really focuses on that mineralocorticoid receptor antagonist that can have leave some activity even after you have these patients on an ACE and ARB. So you still have some benefit to putting them on some sort of inhibitor of that mineralocorticoid receptor. Under normal conditions, when that receptor is activated, it regulates salt and water. But in diabetics and our chronic kidney patients, this tends to be chronically activated because these patients tend to have chronic RAS activation, which leads to excess aldo, and that excess aldo binds that mineralocorticoid receptor and can lend to a lot of excess inflammation, oxidative stress. It can lend to endothelial dysfunction, fibrosis and stiffening of blood vessels, and inflammation as a whole, and a whole slew of other downstream effects as a result, both on the kidney, the heart, and the blood vessel. So traditionally, we've used the spironolactone and eplerenone that can block the mineralocorticoid receptor and helps with some of these fibrotic concerns. But what we know is that spironolactone and eplerenone have great use in heart failure, but have limited use in our CKD and diabetic kidney disease population because of the side effect of hyperkalemia. So in our patients with higher GFRs or lower GFRs, we really are limited in our ability to use. Unlike with finerenone, these are our non-steroidal mineralocorticoid receptor antagonists. finerenone actually has superior anti-inflammatory and anti-fibrotic outcomes, and it tends to bind the receptor more readily and selectively. It's distributed a little bit better when compared to spironolactone and eplerenone. It's distributed in the kidney and the heart a little bit more evenly. And so it tends to have a lower potassium risk than that of eplerenone and spironolactone. And so some of the trials that we can see with finerenone is the Fidelio CKD. This trial was a randomized control trial on type 2 diabetics that added finerenone onto a maximum tolerated ACE and ARB. And what they found is that finerenone significantly reduced primary composite outcome by 18%. And that was kidney failure, whether it was ESKD, drop in GFR, or a decrease in GFR by greater than 40%. It also showed a 14% reduction in the secondary outcomes, and that's your cardiovascular outcomes here that we see. And so pretty good response. And then they noticed that these patients that were on finerenone actually had improvements in their albuminuria versus those on placebo. And even though the frequency of adverse events were very similar between the two groups, the rate or the incidence of trial discontinuation for hyperkalemia was greater in the finerenone group versus the placebo group. And then the next study was the Figaro DKD, and it was a randomized control trial that looked at early stages of kidney disease. So the earlier trial had more cardiovascular risk and less, or the earlier trial had more advanced kidney disease than this one does. This one actually looked at more patients with higher cardiovascular risk and less advanced diabetic kidney disease. And what it found was that finerenone reduced 13% reduction in the primary outcomes compared to that of placebo. And most of that came from the reduction in heart failure hospitalizations. And then I had a few really good kidney benefits with 60.64 relative risk for progression to ESKD. So finerenone tended to fare better in terms of that. As far as hyperkalemia, we did note that there was an uptick in hyperkalemia and discontinuing as a result of the hyperkalemia in the finerenone group versus the placebo group. And then we have Fidelity. This was a pooled patient analysis that they looked at 13,000 patients that had type 2 diabetes, chronic kidney disease stage 1 through 4, and very high albuminuria. And what they saw was a 23% reduction in kidney composite, 20% reduction in dialysis, 14% reduction in cardiovascular endpoints, as well as for hospitalization for heart failure. And these patients also had a slightly higher incidence of hyperkalemia compared to that placebo group. So our indication, KDIGO recommends that we use nonsteroidal mineralocorticoid receptor antagonists with patients that have diabetes and a GFR greater than 25, that still have persistent albuminuria despite maximally tolerated RAS inhibitor, and a normal serum potassium. And so looking over here, we see kind of the comparison between spironolactone and finerenone, looking at both the Fidelity trial that looked at treatment-resistant hypertension, as well as the AMBER trials. The Fidelity trial looked at placebo versus finerenone that we just looked at, and it showed that hyperkalemia was seen in about 11.6% versus that of the placebo. However, if you look at the AMBER trial, which looked at the use of spironolactone, we see that the incidence of hyperkalemia was much greater in that patient in this cohort. And even when they gave those patients patiromer to help control the hyperkalemia, it was still substantially greater than what we see with finerenone. And so recommendation is really in anybody that has a K less than 4.8 with no reservations, going ahead and starting the finerenone. In those that have a K greater than 5, really monitoring these patients a little bit more closely. And then those that have a K greater than 5.5, you may want to either hold finerenone or consider other ways to mitigate the hyperkalemia. And then the last thing is the GLP-1 receptor agonist. And very similarly to SGLT2s, a lot of our knowledge of the kidney benefit came after a wave of cardiovascular outcomes trials show that there was significant reduction in atherosclerotic cardiovascular events, but also showed that there was some delay in diabetic kidney disease progression. So before we look at the trial that kind of really is dedicated for kidney disease progression, we see that GLP activity kind of taking a step back about and looking at the physiology. So this is why a lot of our GLP receptor antagonists have such a wide-ranging benefit. So we know GLP-1s are an endocrine hormone that result from an enzymatic breakdown of proglucagon. And it's synthesized in the L cells of our intestinal, in small intestines and colon, but it can also come from our hindbrain with certain neurons. And it's thought that this is probably what gives the GLP-1s a benefit in terms of affecting addiction behaviors. And then it can also be released by alpha cells in the pancreatic cells. So GLP-1s, we know, have a number of different benefits, but in its natural form, it is actually really quite short-lived. It's only in the circulation for about a minute or two before it's rapidly degraded by our DPP-4s. When it is in circulation, it can bind a number of different receptors, and these receptors aren't just on the pancreatic cells, they're found throughout the body. And so the brain, the heart, the kidney, GI, the vasculature. And this helps kind of explain all the different clinical effects that we're seeing with this group of agents in terms of the GLP-1 agonists. So it's not just there for glucose lowering, but it has benefits in terms of weight, in terms of appetite regulation, in terms of kidney disease, in terms of heart protection, and so forth. And then again, its neurologic effects may play into why we see some of the addiction behaviors being corrected on a GLP receptor antagonist. And it's thought that a lot of the kidney benefits come from its effects on the endothelium. So this slide kind of illustrates potential endothelial as well as vascular benefits that we can have with the GLP-1 receptor antagonists. So the GLP receptors are expressed on the endothelium and end of the vascular smooth muscle. And so they can have direct effects to improve endothelial function, decrease vascular smooth muscle activation, decrease inflammation and lipid accumulation, as well as a number of indirect systemic effects. And for a long time, we've known that GLP-1 receptor agonists reduce albuminuria, but until recently, we really didn't have any trials that were powered to look at just hard kidney endpoints until the FLOW trial. And the FLOW trial has relatively recently come out. And it was a multinational randomized controlled trial that looked at 3,500 adult patients with diabetes and chronic kidney disease that were also on a RAS inhibition. And it randomized them to either receiving semaglutide or placebo. And what it showed was that the major kidney disease events, or the primary outcome, We saw a 24% reduction in that primary kidney outcome. We also saw a decrease in the annual rate of GFR decline by 1.16 in that semaglutide arm. And then it reduced major cardiovascular outcomes as well as all-cause mortality by 20%. So Flow really established GLP-1 receptor antagonists as having true kidney protective benefits to it. And then the consensus between ADA and KDIGO is recommending initiating this on patients that have diabetes and chronic kidney disease that aren't meeting their glycemic control. Here are some of the GFR dosing that y'all can review. And then y'all are aware of a number of the side effects, but it's not just the pancreatic side effects. The most common side effects that we see really are those gastrointestinal side effects that go along with it. So just kind of a summary slide just to look at all the different ways in which each of these pillars affect kind of the different pathways that we talked about very, very early on. And this pillared approach really attacking the progression of diabetic kidney disease from multiple areas. But what do we know about combination therapy? Is that something that we can add on to? And the truth is, we don't really have a lot of large trials looking at combination or the effects of combination therapy at this time. We know that some of the trials that we just went over, those patients, some of them were, or majority of them were on some sort of ACE inhibitor. Sometimes SGLT2 and GLP-1s were also included in the mix, but these were relatively small in number. And so really being able to extrapolate any data is not really there. So one thing that we did look at here, and I think this is an interesting way to look at it, is this trial was published in Circulation. And what it did is it looked at prior trials, Canvas, Credence, the Figaro and Fidelia, as well as a number of the GLP cardiovascular outcomes trial. And it used these trials to estimate kind of a lifetime benefit of using all three pillars, so the SGLT2, the GLPs, and the nonsteroidal finerenone, what that would look like either using them alone or with alone or in combination. And they compared it to the conventional therapy of just being on a RAS blockade. And what they found was when we look here at the cardiovascular outcomes, you see kind of that graded approach. And these are all based on estimations and projections, right? So it's projected that you would have a significant benefit with each addition of a pillar, such that there was, 0.65 hazard ratio when you had an ACE on board along with the 3 additional pillars for cardiovascular outcomes, as well as for heart failure. You see that a much greater benefit that we see, as well as cardiovascular death. This is true also of our CKD progression, as well as all-cause mortality. And then they extrapolated that into kind of the years of event-free survival. And we see that there's a 3.2-year event-free survival with major cardiovascular events, 3.2 for major heart failure events. Kidney events was much greater benefit, and then cardiovascular survival as well, and overall survival. That the combination therapy tended to fare better than the convention. Now, obviously, these are projections and not real life data, so to take that into account. But they actually went through this data set and projected what it would be like if there was, 50% additive effect for all of this. And they still saw a considerable amount of benefit with combination therapy over conventional care, which is just the ACEs and ARBs. So with that in mind, they recommended that maybe we have a very graded approach in terms of how we add on these medications. So our traditional approach right now is to maximize RAS blockade, then add our SGLT2, and then 3 to 6 months later look at mineralocorticoid receptor antagonist, and then maybe consider a GLP. But what they're proposing is in patients that we saw, that patients that actually had higher risk actually tended to have higher benefit, that maybe in patients that have higher risk to consider an accelerated approach where you're following these patients much more closely and adding on each pillar more sequentially than otherwise. I did put over here the kidney failure risk equation. That's really neat, I think, for our primary care physicians, as well as for when I talk to my patients about their kidney disease and what their risk for kidney failure is. I think that sometimes helps kind of motivate them in terms of some of the lifestyle modifications that we're asking of them. And so that's something to kind of play around with, and I encourage y'all to look at and use when you're counseling your patients. And then the last slide, really, because I am over time, the last slide is just the stepwise kind of algorithmic approach. This has been published in KDIGO as well as the ADA guidelines. This just has a different look to it, but really talking to our patients about lifestyle first and foremost is foundational. I picked this particular rendition because it included sleep in the mix too, which I think is going to be important. And we're going to see a lot more impacts in terms of chronic inflammation as well as a result. And then first line drug therapies we have for those patients. This is the type 2 diabetics in the green. You want to, for glucose lowering, you want to really use SGLT2s and metformin as first line therapy. GLP-1 if additional glycemic target is needed. As far as blood pressure management, our first line therapy is going to be RAS inhibitor, large and whole. But if additional therapy is needed, especially if they have proteinuria, consider that mineralocorticoid receptor antagonist. If they don't, you may be able to benefit from, calcium channel blocker or a diuretic, and or progressing onto the steroidal mineralocorticoid receptor antagonist. And then lastly, our statin on most everybody with type 1, type 2, and CKD. Sorry, guys, I think I went much over.
It's okay. Dr. Kaplan has a question. Go ahead, Dr. Kaplan.
Okay, that was a great talk. I mean, I know a lot about this topic, but that was an incredible talk. You gave me a lot of information that for the first time I hadn't heard. One, I just want to make a comment. I'm really glad, and I did not realize that this was available, but your projection analysis that you had, because for finerenone, I had always looked at them and said, gosh, you added this to a RAS and no one had an SGLT2, or a minimum number of people, but not enough to make a claim about a primary outcome. So that makes sense. Almost like heart failure treatment for kidney disease, quick add-ons. My one question, because it's been a frustration, those poor type 1 patients out there. I mean, we get adults that are type 1 who have very bad proteinuria with progressive renal failure, and they do not qualify for an SGLT2 because of the risk of euglycemic DKA. So I bent over backwards trying to get finerenone approved, but it wasn't included in their trials, and it's perhaps being done. Do you have any success in getting patients on that off-label yet?
No, and I think we're finding that too. There are trials being done on finerenone with our type 1 diabetics, and so hopefully that'll give us a little bit more teeth in our request. But yeah, it's been tough. Even in our type 2 diabetics, I think just getting coverage for a lot of these drugs has been more difficult than one would anticipate with the findings that we're seeing with them, the benefits that we're seeing with them.
Because I've had some, and it's gotten past that, but you would put people on it, and they go, a mineralocorticoid, put them on a Clarinone or spironolactone, and you're like, no, this is a totally different mechanism of action. But we're getting less of that now.
We are getting a lot of they're wanting us to prove failure with the spironolactone and the Clarinone before approving the finerenone. And like you said, it's not, it's
Different
apples and
mechanism of
oranges.
action. I've had that more from the VA hospitals than privates, but I guess, yeah, okay. But excellent talk, man. You did a great job. That's one of the best lectures I've listened to this year. You really did a good job with that.
Oh,
Thank you so much. I know you went over. It was worth listening.
Well, thank
Yeah,
you. I
excellent.
appreciate it.
Dr. Boline, there's one question in the chat that I'm going to read to you. Good evening, everyone. This is from Dr. McIntosh. Great presentation with welcome pathophysiology review. Dr. Boline, beyond new medications, what public health initiatives offer the greatest potential to decrease the incidence of ESRD in the diabetic population, as a large segment of this population continue to be negatively impacted by the social detriments of health? Thank you.
So what population, and just to recap the question, so what public health initiatives might be helpful in reducing?
The incidence.
Yeah, that's a great question. That's a big question. That's a great question. I think there's a lot. I think there's a couple of things. One, early intervention, I think is going to be a huge impact for us. You know, up until recently, we really only had our ACEs and ARBs and didn't have much else available. These newer therapies were largely being considered in patients much later in their kidney disease. So I am hoping that earlier initiation of this kind of staggered approach or pillared approach will impact their trajectory in a really meaningful way. So that's one. And then two, I think a lot more in terms of lifestyle management, really providing that education for our patients and being aware. I think there's a lot more on social determinants of health that we may not have been addressing, you know, in prior years. And I think that might also help in terms of our patients having a little bit more success with their lifestyle interventions. I hope that answered.
Yeah, I don't think Dr. McIntosh has a mic, so so that is the only question that's in the chat. Anybody
Do
else
we have
has
anyone
one?
else that wants to pop up with a question? Anyone on the call? Questions or comments for Dr. Bowen? Yeah, well, Dr. Bowen, thank you for doing this. This is something that's so relevant because of the high prevalence of diabetes and unfortunately the prevalence of proteinuria in that group. So that I'm sure that most of the people on this call in one way or another are caring for the patients that you described so nicely this evening. So thank you again for a really nice presentation, and we appreciate everyone being on the call. Hope that everyone will be able to rejoin us next week for the last program for this calendar year with Dr. Holstead and the envenomated patients, as he likes to call it. And we hope you have a great evening. Thanks so much, and thanks for joining us. Thanks to Mary and Jennifer for their help. Take care. Have a great evening. Good night.
Thank you. Appreciate it.